Fantastic. Okay. Hello, everybody, and how great to kick us off for WPE talking about cannabis. Awesome. I am Carrie Franson, and I'm here on behalf of the Pharmacist Cannabis Coalition of California. And we are here to talk about Ryan's Law. Ryan's Law is a law that has already passed. It passed in 2022. And what essentially it is a law in the state of California that says that people who are at the end of their life have the ability to access cannabis while they're in the acute care setting. So the reality of this is, since the law has been in effect, it hasn't really affected a whole lot of hospitals dramatically. It's kind of creeping into the acute care setting. But I have to let you know that as of this legislative session in California, SB 302 is a major change for the way in which we will be doing things. If this law passes, it's currently in the Oversight Committee, Judiciary Committee, and the point of that is that will allow anybody who's over the age of 65 access to cannabis while they're in their acute care facilities. And that's not just hospitals, that's long-term care and so forth. So we, the Pharmacist Coalition of California, the people here, plus we have one member who wasn't able to make it today, but we are committed to making sure that patients have safe access to cannabis, that people like pharmacists are overseeing their use and maintaining the safety of their use, regardless of setting. And so we know that not everybody is prepared to provide this kind of service, have the policies and procedures in effect. And so that's why we're here today. We're going to tell you about Ryan's Law, the law that's already in effect. We're providing you with policies, procedures, documentation that you can take back to your facilities so you can start implementing this and making sure that pharmacists are ensuring that patients have the safest care. So, without further ado, let's talk about what we're going to be doing today. These are our objectives, and just to kind of give everybody a ability to self-assess where they are with regard to these objectives, let's do some self-assessment questions. So question number one, who of the following is qualified under Ryan's Law to use medical cannabis in a California healthcare facility? Any patient with a California medical cannabis card, terminally ill patients regardless of possession of the medical cannabis card or written documentation, terminally ill patients with medical cannabis card issued outside of California, or terminally ill patients with either a California medical cannabis card or written documentation from an authorized provider. Okay, so this is actually specified in the law, and if you don't know the answer to this, question two, true or false? Pharmacy and our nursing staff will be required to dispense and administer patients' own cannabis. True or false? We'll find out. On a federal level, cannabis is considered hemp if the concentration of THC is less than 0.03%, 0%, greater than 0.03%, less than 0.03%, or less than 0.5%. Question four, which of the following cannabis products will not be allowed in a healthcare facility pursuant to Ryan's Law? Oral gummies, sublingual tinctures, vape pens, or topical lotion. Question five, the primary agency authorized to enforce Ryan's Law in a healthcare facility. Note that language. Enforce Ryan's Law. So therefore, our acute care facilities are compelled to do these policies and procedures. Is it the DEA, the California Department of Public Health, CMS, or the FDA? So that's what we're going to be covering today. Hopefully you'll be able to, if you don't know those answers already, you'll be able to answer them with great confidence. But what I'm going to do is kind of lay the land about medical cannabis by turning it over now to my colleague, Dr. Cody Peterson, who has a master's in cannabisology or something along the lines.
Thank you, thank you. I thought you were going to take it. I was like, oh, I'm going to sit back down. So my name is Dr. Cody Peterson. I'm a practicing pharmacist at Children's Hospital Orange County. I still work overnight. I'll be there tomorrow night. So hopefully I'll see you there. We want to talk about medical cannabis. I want to make this relevant for you. I want you to understand that this isn't something that is sort of pie in the sky. It's also not some street drug. This is medicine that we're using today in the hospital, in healthcare. And you need to get ready for it because it could potentially come to all of your senior citizen patients, depending on what the legislation in our state decides to do. So 4.4 million patients use medical cannabis in 2021. That number is a lot bigger if we move out of medical. We're talking about 20 million Americans in the last year. 20% of all your Medicare patients are going to be using medical cannabis. 20%, the biggest cohort of patients that we have. And then interestingly enough, two out of 3 doctors are actually in favor of medical cannabis legalization. It goes further. The most recent Pew report suggests that 91% of Americans are in full favor of medical cannabis, and nearly 65% of them in favor of adult use. So, all this to say, this is important, this is pertinent, and it's right now happening in this country. You to be the expert to know about it. But you can't be an expert on something you don't understand, right? Before you get to learn about epinephrine, you learn about your alpha and your beta receptors. Well, before we get to learn about THC and everybody's favorite herb, we have to learn about the endocannabinoid system. Now, you might be sitting here thinking, I've never heard of that. Or maybe you already know all of this and you just came to give me feedback at the end. But more than likely, you weren't taught about this. There's a couple reasons for that. Number one, it wasn't discovered until the late 80s, early 90s. So, for some of us, Rafi in the front row, we didn't have pharmacy school since then. But alternatively, still to this day, only 10 to 15% of medical schools are even covering this in their curriculum. Why? Well, we don't really understand it that well. We don't have the type of information we want, and probably, and unfortunately, we don't have any good FDA-approved drugs that are activated in the system, so we're not teaching it to our pharmacists. Of course, we do have FDA-approved drugs made of cannabinoids that act on this system. One is known as Marinol, THC, synthetically derived. We use it still to this day. Syndrose, the liquid form of THC, also a synthetic THC isolate. And CBD, Epidiolex, a medicine I use in the hospital regularly every day. So this is very pertinent. Now, let's talk about the system it acts on. The way I like to describe this is a master regulatory system. If I talk to you about your GI tract, you can point, right? You can go, oh, this is here. So if my GI tract is here, I have an organ system to point to, the nervous system, something similar. This is not that. Okay? It would be great if it was it's right here, but it's not. It's everywhere. The endocannabinoid system is a master homeostatic regulatory system found in all vertebrates on planet Earth. So if it has a spine, it's using molecules inside itself to create balance to maintain homeostasis. What is it maintaining? Body temperature, wakefulness, hunger, sleepiness, all of these things. If you can get deep into the weeds here in our GI tract, you can see that the CD1 receptor mediates gut motility. Well, that's a problem that we know we deal with in the hospital regularly. In fact, we have drugs that activate, or that improve gut motility, or slow it down, intentionally or unintentionally. So again, found in all vertebrates, this system is a lipid signaling system. This is factor number 2 that made it difficult for us to learn about it and why you weren't taught about it. All the systems we learn about are water-soluble systems. When we learn about alkaloids, most of the drugs that we deal with in pharma are this water-soluble form. This is not cannabis, it's the opposite. It's fat-soluble, it makes for a more complex drug with more complex kinetics and some interesting pharmacology. And when we talk about the endocannabinoid system, you need to appreciate that the CD1 receptor, you can see that it's found in the nervous system. This isn't just important, this is the most abundant G protein coupled receptor in the brain. It's more abundant than your dopamine and serotonin receptors. It is playing a critical role in keeping everything in balance, including those systems. It has a direct connection to the serotonin system. It's secondarily connected to the dopaminergic system. The GABAergic neurons are covered in CD1 receptors. Okay, so the system is present in almost all life on planet Earth. Super important to our nervous system, and also to our immune system, our inflammatory response, and many of these other factors that we are learning are increasingly important for the diseases that we're treating today. So this is my favorite system. It's super cool. As we learn more and more about it, we've learned that CD1 and CD2 is probably a little naive. In fact, when we keep diving into this system, we find that there are more and more receptors playing in this larger system, which is a little above the scope of our talk here today, but I would love to teach you about it in the future. So what is a cannabinoid? You know the one, THC, right? It's FDA approved. You all better know about it since 1984, 1985. Okay? THC is a cannabinoid. Where do we get that term? Well, it interacts with the cannabinoid receptor, started first identified in the 1990s. So what do we have? We have 3 different types of cannabinoids. We've got the ones that our body makes, endocannabinoids. Just like you make endorphins, endogenous morphines, you make endogenous cannabinoids. If you look at your phytocannabinoids, phyto, the prefix meaning plant, there are plants that make molecules like this, namely the cannabis plant. And then lastly, you can see that there are synthetic cannabinoids. Rest assured, pharmaceutical companies are aware of the information I'm teaching you. I promise. They've known about it since the 90s when we first discovered it. They've been actively pursuing pharmaceutical medications that manipulate this system for over 25 years. I've got a couple examples for you. So the first is Rimonabant. Rimonabant was not FDA approved, European drug approved in 2005. It was on the market for 2 years. Does anyone know what we're treating? Obesity, metabolic disorder, a problem that we still struggle with today, maybe even more so. Okay, so what were we doing? We were blocking the CB1 receptor. So now, if you think about THC, cannabis, it induces hunger, right? So if I block my CB1 receptor with Rimonabant, CB1 antagonist, I can stop that feeling of hunger. I can improve satiety and lose weight. And it turns out people did lose weight. They also had an increased risk of killing themselves. They also had an increased risk of depression and numerous other problems that arose when they started taking this CB1 blocker. So think about it. If THC makes you feel X, and then I reverse that effect, like the opposite effect of THC, you could imagine that would be a negative effect, and that's what they found. It was removed just 2 years after it was approved. Nalgalone is Sesamet. This is FDA approved on the market today. It's a synthetic cannabinoid. It probably looks most similar. Let's see if I can get my laser. Looks most similar to HU210. It's a very potent agonist. If 5 or 10 milligrams of THC will get you high, 1 milligram of Sesamet will get you high. It's FDA approved for chemo-induced nausea and vomiting, wasting syndromes. Why isn't it used? Because it has side effects. Because it turns out that nature made a pretty dope molecule when it made THC, and scientists made a mediocre one when they made that one. So it's not commonly used, and it hasn't shown as much benefit for a lot of patients as our phytocannabinoids. Now, that's what we're talking about. We're talking about cannabinoids, but now we need to talk about how we deliver them, right? Route of administration. So you've got your inhalables. That's a no-go in California, Ryan's Law. No inhalables permitted in the hospital. I think that keeps everything easier. Probably improves patient care too. So you can inhale by smoking, but you don't have to. We can extract an oil, and we can heat that up gently, and we can deliver that through a vape pen. It comes with its own set of problems, challenges, and safety concerns. There's the drier vape that you may not be familiar with, but if you're a medical cannabis patient in Israel, who sort of led the way in medical cannabis, you were actually issued a state-issued vaporizer. They give you your device to inhale your flower from. Oral, so we got your sublingual oils, right? This is just a simple extraction of these fat-soluble cannabinoids into another oil. Patients either take this orally or sublingually. Some contention around the pharmacokinetics of how that sublingual dose is delivered. Edibles, you know this, your brownies, your cookies, all of those good things. And this is a beneficial or useful drug delivery system because we know that this is a fat-dependent molecule. So when we deliver almost all cannabinoids, they like to go be absorbed with fats through the chylomicron system and move their way through that, right? As opposed to your typical portal vein to the liver. Your capsules, obviously, we don't have any. You have it all. Topicals, this is interesting. We don't talk much about topical cannabis, certainly not approved. I have a lot of patients and a lot of personal friends who swear by this, and there's a lot of pharmacologic underpinnings to why this might work. The channels that are being activated on our skin by these plant molecules might actually be more predictable than you think. The example I want to give you is capsaicin. Capsaicin, hot chili oil, right, activates a receptor on our bodies. You may or may not know TRPV1. TRPV1 is an ion channel, and CBD axon, and CBG axon. And if we keep going, TRPM8 is another ion channel. It's how menthol makes you feel cold. CBD interacts with it. Other cannabinoids interact with it. And the terpenes found in cannabis, the essential oils, also there. So this is not some mystical system that doesn't exist. We're already manipulating it. We're already attacking it today. Products available on the market. And then lastly, suppositories. I don't need to explain, but could offer a lot of hope. The endocannabinoid system is in my uterus, which it is, not my uterus, but that's not the point. The endocannabinoid system is present in almost all tissues within the body, and as such has the potential to deliver therapeutic responses. Or, obviously has an adverse effect. Just a reminder, no smoking in hospitals, because we do want to keep patients safe. That's a big concern. And I think it's probably the biggest concern of everyone in this room right now is, how am I going to deal with this substance I don't know about? I don't even know what it looks like, right? What does this flower even look like? How do I handle it? What is the right dose? It's questions. I don't have all the answers, but I can assure you that this is a substance we have a lot of experience with, and assure you that patients are using this substance already, whether they have your help or not, and that we can use our skills, what we do best as pharmacists, to improve their care, and maybe improve their care. I clicked ahead, but I did want to point out CBD in the green. So we've been talking about THC almost the whole time, the intoxicating cannabinoid. CBD, another cannabinoid produced by the exact same plant, has different side effects. Yeah, it looks like drowsiness is there, just like every other FDA-approved medicine we know of. But diarrhea is interesting, and insomnia. So the opposite effect that we saw with THC, and I wanted to highlight that. So these are the common adverse effects. You should know about them, but none of these change our plan usually, right? Pretty much look at all these and say, oh, we can do it. The next ones are a little bit more serious, okay? And I've definitely seen these problematically in my career. Acute psychosis and cannabinoid hyperemesis syndrome. I work in an emergency department. I see this, okay? It's not my favorite thing to deal with, but I absolutely see teenagers with CHS, and I absolutely see adults who consume too much cannabis and are coming on loop. Now notice it says acute psychosis and not schizophrenia. Cannabis may be thought to be associated with schizophrenia or earlier onset, but cannabis so far, even in twin studies, has not been shown to induce schizophrenia, so that's a big little sure. But acute psychosis, absolutely. You take too much cannabis, you can call the police and tell them you think the time stopped. It's happening. So orthostatic hypotension, the cannabinoid receptors are prevalent throughout your entire vasculature, all over the endothelium. Okay? So when we activate them, we have a vasoactive agent, and what we typically see is a drop in BP. Not usually a major problem for our patients until they stand up too quickly and they fall over. This is something that we can manage and mitigate as pharmacists with proper counseling. We do it all the time in medicines already. CHS, just because I want to give everyone some context, this is cannabinoid hyperemesis syndrome. This is when the endocannabinoid system is thrown off balance from chronic consumption of THC. And when that happens, patients present with a very stereotypical pattern of symptoms, almost always with a chronic underlying nausea going on persistently for weeks, if not months, heartburn, morning indigestion, diarrhea, but it's not really associated with the vape pen. It's almost always a vape pen in my pediatric experience. It's not associated with the act of smoking. So they don't associate these symptoms with the act of consuming cannabis. But it turns out the master regulatory system that is the endocannabinoid system, when exposed chronically to THC, does have potential to be thrown out of balance, potentially people are genetically predisposed. What ends up happening is you fall into a cycle of nausea and vomiting, sometimes lasting days, if not many days, even a week, of inability to vomit. Cannabis is frequently touted as you can't die from cannabis. And that's true. The overdose of cannabis, you need to smoke something like 4 pounds of cannabis. You can't do it. But there have been a few deaths associated with CHS, associated with electrolyte derangements, from people who continue to consume, continue to vomit, go to the hospital, they get their IVs, they go home, they go stay through the cycle, and unfortunately will have to die. So, just for your edification. Hepatic enzymes, CBD is definitely a concern. So when you're thinking about CBD, you're going to be thinking about CYPs, and we'll get to that section. Okay, so other concerns that you might have, I want to address them. I don't have an answer or solution for all of them, but we all need to talk about them. So driving while intoxicated on cannabis has been associated with the reduced functionality, with a more deviation from the center line, etc. Now it has not been associated with the same level of alcohol. Certainly it's not indicated with the same level of accidents, but when combined with alcohol, THC can be quite intoxicating. Alcohol allows it to pass through the blood-brain barrier easier, and impairment is almost certain. So driving can be dangerous. Smoking anything is bad. There is a lot of tar in cannabis smoke. However, there is not nicotine, and that matters. It appears, this is mostly still speculative, but all studies that have looked at cumulative cancer risk show that cannabis smoking alone, not co-smoking, cannabis smoking alone is not associated with increased cancer risk. However, it is associated with bronchitis, function changes. Okay? But as far as cancer, the jury so far has said not guilty for THC on cancer, and this is likely to do with THC has a tendency to induce apoptosis, whereas nicotine has a tendency to induce cellular proliferation. So that's for more reading for y'all. Unstable heart disease, super important. THC is vasoactive and it's cardioactive. It will change it can induce tachycardia, so affect chronotropy, and it can also affect the rate, the pace at which electrical signals are sent across the heart. So patients at risk of flutter, AFib, etc., high risk, especially with smoking THC. Pregnancy, I don't need to get too into it, but there are concerns around the development of the fetus. At week 12 of the fetus, we see the first endocannabinoid receptor, and it's involved highly in neurogenesis. Okay? So we know this is important to the baby's brain development. And introducing THC could have negative effects, although most studies so far have not shown terribly dramatic, and as far as we know, no teratogenicity, which we know is a biggest concern. Minors, I see this every day. There are worse things for kids to do than weed, but it is a problem. If we were faced with, stimulants, alcohol, and cannabis, I tell the kid go cannabis 5 times out of 10. But if none of the above is an option, obviously that's the right choice. Okay? I think it goes without saying. But there has been changes to brain matter. The more a teenager smokes, the more likely they are to deal with something like anxiety, impulse control, and things like that. So we do want to keep cannabis out of THC, not cannabis, out of the hands of children. Adultery products, I'm not going to get too much into this because y'all already know what adultery is, but there's no regulation on the CBD market. Okay? California cannabis is regulated. Does that mean it's perfect? Far from it. Does that mean it's not harmful? No, not necessarily, but there's something. The nationwide MCBD market that opened up in 2018 is basically unregulated. Okay? No one's testing these products. There's no mandatory. The feds don't have any flex. So unless you're making medical claims saying you cure cancer, they're not going to do anything, even if your product is tainted or you hurt symptoms. And then later, super important for reasons that I don't need to explain to you. We could quickly go through drug interactions. You can figure these out, but basically we wanted to highlight the narrow therapeutic drugs that we do know there are drug interactions. There's a lot of hypothetical drug interactions. You can find 500 of them listed on drugs.com. Not that any of us have ever used that tool, but what we do know is THC has been reported in numerous case reports to interact with warfarin. Increased warfarin effect, increased INR, bleeding, risk, we know this is bad. CNS depression, opioids, and anticholinergics. Okay, anticholinergics, it says ataxia, but that's just like more anticholinergic effects. So what's this? This is tachycardia, this is dry mouth, this is dry eyes, all those things. And then opioids, depressants, etc. Synergistic effects, right? This is a pharmacodynamic interaction. They can both work together to reduce your sort of overall need for the other medicine, but also how much sedation you get. So sympathetic mimetics, any drug that's stimulating the heart, can also synergize with THC in a potentially negative way to increase heart rate and alter blood pressure, and have mixed effects. And then propofol, there is an interesting effect that they've noticed that patients who smoke cannabis regularly might need more propofol to go to sleep. And the effect of that, not well established, right? Anesthesiologists have to give more drug usually. But there is this concern around an increased need for sedation. Could be related to effects on the GABA system induced by the THC exposure. CBD, definitely warfarin interaction. This one's like red flag status. Okay, CBD has mixed actions in the CYP system, and it's definitely an inhibitor. Inhibits increased warfarin, and this is a big risk. Your immunosuppressants, narrow therapeutic drugs, right? We go too high, we have serious problems, seizures, kidney injury, etc. So anything that's going to alter their drug concentrations we're concerned about. CBD is a potent inhibitor of 3A4, 2C9, and 2C19. I don't remember if we have a slide on that specifically on this. But you can find a lot more information about this on our website at PCCRx.org. Okay, finishing up. CBD was approved for chronic seizure disorders in kids. I use CBD in the hospital regularly again by patients, epidiolex, and we're concerned about valproate levels and clobazam levels in those patients with respect to valproate because of the hepatotoxicity and the high doses needed for prescription CBD, up to 20 milligrams per kilogram. We have an increased risk of LFT problems and liver injury. And then the last thing I want to make note of is clobazam, because FDA approved FDA-approved CBD is often Epidiolex, approved for a unique set of pediatric seizure disorders. Onfi, or clobazam, is commonly given together. We actually see an increase in the active metabolite accumulating in Onfi, so we see increased sedation in our patients that we treat with that. So, recognizing that not every medication is going to do the same thing with SIPs, it is possible that CBD could raise or decrease the level of the drug you're looking for. So it is a promiscuous ligand with CYP enzymes, so we need to be aware of it. And I am done talking, thank goodness. All right, here we go.
All right, that was in 20 minutes. So I'm here to set a little bit of the groundwork about what do we know and what do we understand about the federal and state laws and regulations regarding cannabis. So the biggest thing you have to recognize is we've been talking about cannabis, and perhaps you've been thinking about marijuana. Where's marijuana? And where's hemp? So the reality is, see this happy farmer over here? He's growing. This guy over here, he's growing cannabis, marijuana. The guy over there is growing hemp. What's the difference? Quite frankly, they're the very same plant. They've been interbred. And the only difference has to do with the federal designation. And the federal designation is any cannabis plant that has more than 0.3% THC in it is marijuana. Okay? So it's regulated like marijuana. This has been since 2018 with Farm Bill. So anything that is 0.3% or less is hemp. Okay? So this is an incredibly important thing, because even when you look at different products that are available in different stores, dispensaries, and some pharmacies, they talk about this is hemp-derived cannabinoids or something along those lines. It's having to do with the federal designation of that particular cannabis. When you look at federally and how the laws and who's regulating cannabis, we look at the DEA and the FDA. So as you know, DEA says, marijuana is a Schedule 1, so there is no approved or medical use for it, and there's a possibility of addiction and adverse effects. And so marijuana is seen as that, except for the FDA drugs that have been approved. Notice that hemp is not scheduled, so that is not something that is defined here, because again, 0.03 or less is a hemp plant. FDA, on the other hand, says that they have approved, for example, Epidiolex, which is the solution, the CBD solution that's been available also since 2018. And it's also said that no cannabis product, whether it came from marijuana or hemp, can be a dietary supplement, because we have real pharmacological action as evidenced by the THC approved drug Marinol and the FDA approved drug Epidiolex. So they cannot be a dietary supplement, and so therefore it's not legal except for those FDA approved drugs. I will tell you, and you probably have noticed, the most prevalent thing you will find in federally controlled areas like airports and even some pharmacies is you will find topical CBD. Why? The reason is there is a small loophole here that the people are trying to take advantage of, and that is if you have a topical product, you can market it as a cosmetic, and CBD is not considered an illegal adulterant of a cosmetic. Okay, so it hasn't been called out as that. So it's kind of in that gray area of, yeah, you can put it in there because it's not an illegal adulterant, but of course, you can't also say it's a drug and it helps you anything, because then it has a different situation. So, but that is why you will see it more readily than any oral agents and everything. The biggest problem about that, though, is particularly with CBD, is almost all Americans think that all these products, when you see them in places like airports and pharmacies and so on, that the FDA is regulating. You heard from Cody, he said they're not, there's not oversight. let's take a look at what happens in California. So California was unique, right? In 1996, they said, let's legalize medical marijuana for those, kind of for a compassionate need, for those who need it. And the idea was, let's just let people who have specific illnesses be able to access it if their doctor says that they could possibly have benefit from it. Okay, let's protect the doctors from being involved in this thing too. I don't know where we were in the whole process, but apparently, you know, pharmacists weren't mentioned in the law and really haven't been in the state of California since. But the biggest thing was, it's like, listen, let's let people utilize it, they can grow it for their own use, as long as it doesn't kind of turn into an illegal activity, other people are in danger, and so forth. So when you look at medical marijuana laws that have exploded across the country since then, you know, different legislators have had compassionate requests by their constituents to approve different particular illnesses to be allowable to be used for medical marijuana. And when you look across the country, you can see that for some states, like end-stage renal disease, there's one state that allows that to be, and that's Washington, right? But then you get other states like ours, those are shown in red, California, HIV/AIDS, us and 31 other states are allowing patients to use medical marijuana to help them with their HIV and AIDS symptoms. So this is kind of the way that things progressed over time, although California did add a catch-all statement, and that is for if your physician says cannabis can help with any chronic condition that you have, then you can go ahead and use it. And this is important because of that law that I was telling you about that's coming down the pike. That's exactly what they're saying. So anybody who is 65 or older and has a chronic condition, it falls into this cannabis compassionate use law. So that's what they're looking for. So for us, when we look at the current legal environment, us with PCCC, what we're looking at is the situation where a lot of people are out there, are trying to use cannabis to help with their symptoms. And when we think about what's happening when they come into the acute care environment, you know, traditionally we've said no, hands off, you know, we receive federal money, we're not going to deal with that here. And our point of view is that really leads to a problem for our patients, right? We're not able to do any kind of medication reconciliation, looking for problems like the contraindications that Cody talked about. We're not, you know, creating the same level of care for patients out in the outpatient environment when they come to our acute care facilities. You know, it's like, hey, let's start another drug because we're not having the patient utilize whatever product they were utilizing in the outpatient setting. And of course, they have to discontinue that when they return back. And as a matter of fact, we do know, we did learn of some institutions that when patients were using medical cannabis for particularly pain treatment, that the policy was to put that patient on an opioid. So again, you know, that's not probably, you know, wise to be the policy. And then lastly, it really, you know, our thinking is by not allowing cannabis to be in the acute care facilities, that we just can't monitor what's happening when patients are using it. And that's probably the biggest concern that I have when I've been looking through all the cannabis literature over the last period of time that I've been involved in this area, and that is we really don't have a good idea of long-term outcomes for patients who are utilizing these products. We have a lot of small, short-term studies, so why don't we get involved, particularly in acute care environment, and see what's happening with our patients as they take these products. So that's part of kind of where we're at, the legal landscape. And now we're going to go into a deep Ryan's law, and I'm going to pass it over to Dr. Law.
So I'm reminded I put on my Jerry Garcia tie today. Jerry Garcia was a patient of mine. He had access to cannabis products. The other important thing, however, is that he was a diabetic. So what do you think is happening to, what happens to a diabetic who uses cannabis? some of the thoughts that you need to begin to think about clinically in terms of what's happening. Shifting from Jerry, what about Ryan? Who was Ryan? How did we get there? And so forth. And so let's talk a little bit about him. He was a 41-year-old gentleman from the state of Washington who had pancreatic cancer. He was being treated with opiates. He did not like the effect of opiates. He was hospitalized. He wanted to use a cannabis product, and the hospital that he was in the state of Washington said, no, you can't do it. What he ended up doing was transferring to another hospital which said, yes, it's okay. Now, for those of you who are hospital pharmacists, what do you think about bringing drugs into the hospital that pharmacy doesn't have any affiliation with or dispensing, et cetera, et cetera? It represents a 180-degree change from the way hospital pharmacists usually practice, and frankly, how all pharmacists practice. We'd like to know what you're taking, how much, et cetera, and is there a problem associated with it? He died in 2018 from his disease, and so what about it? Was it beneficial? Well, anecdotally, yes, it was. He thought it was a good thing. And you'll see in the literature that there's some change between the use of opiates and changing it for cannabinoids and an ability to reduce the cannabinoid dosage. So what happened was a senator from Southern California introduced a bill in the legislature, and the governor signed it, SB 311, in September of 2021. This essentially allowed for the compassionate use of cannabis in hospitals where the patient is terminally ill. There were certain exceptions, as been mentioned. For example, you can't use it for smoking, but you could take it orally or drops or other such things as that. The patient had to have it locked up by themselves or their caregiver, so it never went through the pharmacy. There was some question about what's in there, where did they get it, what was the potency, was it labeled right, et cetera, et cetera. And we then had additional changes to the legislation the following year, September 22, which now allows for patients who are over 65 years of age and who are terminally ill or have a chronic disease which is impairing their lifestyle or daily activities to use cannabis products in the hospital setting. And so the bottom line of this is that it is expanding rather rapidly, and the real challenge, first of all, for hospital pharmacists is how are we going to control this at all, and if so, how? Because the legislature has basically said it's up to the patient and their caregiver, and no hospital personnel may touch it. The only thing that may be required is a documentation in the patient's record, and that the physician needs to recommend it. If you look at the law closely, physicians do not prescribe cannabis as we know it, but they recommend it. And we are also seeking some changes to allow pharmacists to be in that same position so they may have a broader view. So there's some details about federal legislation and state legislation, and Dr. Simonian will take on that discussion. Jill?
Thank you. All right, so I have the privilege of discussing all of the ugly stuff about this. First, we're going to talk about the summary of Ryan's Law and the requirements. What is specified? So, okay, thanks. So the original bill 311 was a little bit more vague. It was cleaned up a bit with 988. So 988 is the bill that is in effect right now. This is specified very clearly now, terminally ill patients only until 302 is passed, if it is. Patients have to have a medical marijuana card issued by the state of California. or written documentation. There's always a loophole somewhere. It must be in a locked container at bedside. Now, 311 didn't exactly specify this, but 988 does. There has to be a medical record documentation of the patient using cannabis. No emergency departments are included. And again, as you've alluded to, inhaled products are prohibited, so only any other product except inhaled. Patient must provide the product. Now, this was not specified in 311, but it's very clear in 988. Patients must acquire, dispense to the patient or caregiver, administer and remove the cannabis once the patient is discharged. Now, this is all under the purview of Prop 215. So this is a state law, and 988 has to be done with compliance for 211. Okay, so here's the ugly part. What isn't specified? So they gave that, believe it or not, it's like a 1.5-page bill. It's very small. They just said, basically do it, but we're not going to tell you exactly how. So policies and procedures are not specified. They give you no direction. How to verify a medical marijuana card or written documentation. Now, you have to have it, but how does anybody know how to do that? People don't even know how to get a medical marijuana card in California. And how to document it. Do we document it? It says it has to be in the chart, but how exactly are we going to do that? And any kind of guidelines for pharmacists are not specified in the bill. And then there's this, the agencies that we're most concerned about. I don't know, this is probably what most people are concerned about here are these agencies. So the DEA, CMS, and CDPH. These are the concerns that healthcare facilities have in trying to implement this law. So let's start with the DEA. Cannabis is still a Schedule I substance under the DEA. So are healthcare facilities going to be in violation of the CSA if they allow a patient to have cannabis in their facility? So, it's not the cleanest bill ever. There's no exact answers, but we're here to try to help you mitigate some of these factors so that you're in compliance with these federal agencies and the state laws. So number one, the facility will not purchase, facility or pharmacy will not purchase, dispense, or possess cannabis at any time. As specified in 988, the patient has to acquire, administer, and remove the cannabis. So the facility really does not touch it at all. So there's no hands-on activity by any employees. Nobody ever touches it except for the patient. So we can sort of feel comfortable about that. We are also somewhat protected by the Rohrabacher-Farr Amendment, which prohibits the use of federal funds to prevent states from implementing their own medical cannabis laws. So federal funds cannot, DOJ says you can't use any federal funds for going after states with their medical cannabis laws, as long as their state laws are followed. So the DEA will not enforce the CSA as long as state laws are followed. I'm sure that makes you feel a lot better. Okay, what about CMS? Everybody says we're going to lose funding from CMS because they're going to ding us on this. If we have cannabis in our facility, we can't have that. But again, it's the Rohrabacher-Farr Amendment. There's the federal funds can't be used to prosecute or go after facilities as long as they're in compliance with their state laws at this time. Now, that was passed in 2016. It's been renewed every year since then, despite different presidential administrations. Doesn't mean that it will continue to be renewed. But as it stands now, that's the amendment. Okay. CMS does not actually address the use of cannabis and its conditions of participation. CMS relies on other agencies to enforce or to ensure compliance with their conditions of participation. And that agency is CDPH in general, and some private companies like the Drug Commission. So CDPH is the primary enforcer of Ryan's Law. So CDPH must enforce California state laws, which includes Ryan's Law. CMS has also stated that they will not cite facilities unless the Department of Justice makes a specific ruling against cannabis use. So if there comes a federal law that says specifically states can't use cannabis or something like that, I don't see that happening. And no provider up to this date has lost any funding for having cannabis in the facility. So CDPH, are they going to report penalties to CMS? Probably not. They need to enforce state laws. That includes Prop 215, the Compassionate Use Act, as well as Ryan's Law. So CDPH very clearly stated in 988 that they must enforce this law in state facilities. Okay, and then there's Title 22. So Title 22 is also, it's a California Code of Regulations. This is another concern about bedside medications. Are you violating bedside medications by allowing cannabis in your facility? So number one, Title 22 states that there must be an order from a lawfully authorized prescriber. That is what happens with Ryan's Law. That also states Ryan's Law, in Ryan's Law. Title 22 states that it must be kept in a cabinet, drawer, or locked container at a patient's bedside, and 988 also specifies that. Title 22 says there are no Schedule 2, 3, or 4s next to the bedside, and so SB 311 initially had that in their bill. They specified no 2, 3, or 4 next to the bedside. 988 repealed that. I don't know why that it's not in there anymore, but we feel like it's important to just specify that in our policies and procedures, so we did retain that in our policies. And it must be, bedside meds must be examined by a pharmacist. So I think that's the hardest one for everybody here. What are you going to do? How are you going to do that? So we think it's important that pharmacists take ownership of this. As Carrie said, this is coming down the pipe with a new law that pretty much anybody over 65 can use cannabis. So we need to take ownership of this and learn how to do this. So our policies and procedures also include some templates that show pharmacists how to characterize the product. Now, we think the pharmacist should examine the contents and characterize it to the best of their ability. Obviously, it's not labeled exactly like an FDA-approved drug. There's different problems, there's so many different variables, but we can try. And I think we should try, and we can, and you don't even have to touch it. You can look at it and still read it and write it down, and document it, keep it by the patient's bedside. And then, as Carrie said, then we have some data, and maybe we can start looking and seeing what the efficacy is for these patients. If there's a lot of patients, this could be a lot of real-world data that we can use for cannabis use, the efficacy, and the safety, so that we have a better idea. So as I said, we have written policies and procedures outlining all of this. It's almost time.
How much time?
Okay.
125.
Okay. Sorry, I want to have questions for you guys. So we have policies and procedures. We've written them. We've outlined everything for you so that it can help walk you through this. Now, every facility is going to want to do something maybe a little bit different, but we've given you a really good base. Carrie's holding a QR code. And there's on the back table, I believe, as well. Yes. If you scan that, it'll bring you to a quick survey with your email address, your name, where you work, and we will send you our policies and procedures, free of charge. And we also have the templates, so we have a waiver, we have a template for the product characterization, and we also have a fact sheet with cannabis facts and drug interactions and safety, so that you can use those. All right, I know it's time to go, so I'm just going to run through these questions real quick. Oh, I guess they're already circled, so nothing really quick. Okay, obviously terminally ill patients only so far. I made these slides and they were right when I did.
That would be a false.
I'm not sure.
Maybe it's going to change. I don't know. Yeah, so that's nobody's going to touch it. Hemp is less than 0.3% THC. Anything over that is no vape pens, no inhalable products. I swear I did this right. CDPH is the primary enforcer of this law, making sure that we're in compliance with Prop 215. There's a bunch of references for you.